False craniosynostosis. By the end of the lesson, you should be able to identify craniosynostosis, list its clinical presentation with abnormal head shape, know in brief the management options. Craniosynostosis is premature closure or fusion of the cranial sutures, leading to union of two or more bones to form a single bone. What is the difference between microcephaly and craniosynostosis? In microcephaly, the shape of the skull is usually normal, and the suture line will be felt normal. In craniosynostosis, the shape of the skull is usually abnormal, and the suture line will be rigid. How does craniosynostosis present clinically? By closure of a single suture is common. Depending on the severity, the child may have some or all of the problems: abnormal skull shape, abnormal forehead, asymmetry of the eyes and/or the ears. The abnormal shape in case of single suture synostosis, scaphocephaly due to sagittal synostosis is the most common type, leading to elongation of the skull or head to be dolichocephalic or scaphocephalic, with long anteroposterior diameter and short transverse diameter due to longitudinal or parallel deposition of bone along the sagittal suture. For coronal suture synostosis, if unilateral, which is more common than the bilateral, will lead to frontal plagiocephaly around 20 to 30% of the cases. Bilateral coronal synostosis will lead to dolichocephaly or brachycephaly. In trigonocephaly or triangular head, it is the less common, 5 to 10% of the cases, where the shape of the face is protrusion of the forehead due to metopic suture synostosis. For lambdoid suture, it will lead to posterior plagiocephaly, abnormal shape of the skull. It is the least common. How does craniosynostosis present clinically? We said the abnormal shape in single suture, but in multiple suture affection, there will be increased intracranial pressure, which can possibly cause impaired venous outflow. It is often caused by hypoplastic jugular foramen. This causes an increase in the intracranial pressure and can be further complicated with a possible acquired anal chiari malformation. Papilledema and vomiting will be present. Delayed development can occur. Seizure and blindness due to pressure on the optic foramina and compression of the optic nerves causing optic atrophy. Some genetic syndromes are associated with craniosynostosis. Most of them are rare. We have Crouzon syndrome, it's autosomal dominant. There is craniosynostosis with brachycephaly and ocular proptosis due to small sockets and hypertolerism. Carpenter syndrome, it is autosomal recessive. There is acrocephaly or brachycephaly with polysyndactyly. The fingers will be fused together. Apert syndrome, autosomal dominant, brachycephaly and syndactyly. How can you evaluate the brain for structure abnormalities associating craniosynostosis? Usually, there is no, in isolated cases, just bone deformities. MRI Drain will be done if you suspect structural abnormalities as hydrocephalus, agenesis of corpus callosum, and in excluding other causes of asymmetry of growth of the head as brain atrophy. Three-dimensional surface reconstruction CT scanning can help the surgeon to plan surgery for reconstruction in cases of cosmetic correction. What is the treatment option in case of craniosynostosis? In single suture, it is conservative, just for mild cases. Follow-up, growth and development, signs of increased tension, and optic nerve follow-up by fundus examination. When to do surgery, when to intervene, and why? If there is increased intracranial tension with optic nerve compression, this is an emergency management to decrease the compression, separate the sutures. Otherwise, it will be for cosmetic improvement only. In cosmetic surgery, just to improve the shape as the uppercase agoricocephaly and the lowercase trigonal cephaly.